Olá, boa noite a todos. Meu nome é Evanilson Aquino, eu estou aqui para coordenar essa webinar. Nós vamos falar hoje sobre cuidados de fisioterapia na fibrose cística. Então, inicialmente, eu queria agradecer a todos os presentes e falar que essa iniciativa ela foi idealizada pela Sobrafir, Associação Brasileira de Fisioterapia Respiratória e Terapia Intensiva, em parceria com o Grupo de Estudos de Fibrose, o Grupo Brasileiro de Estudo em Fibrose Cística. A nossa associação tem demonstrado um compromisso profissional, com os profissionais da especialidade no qual ela representa, trazendo informações em tempo real de tudo que tem acontecido no mundo relacionados aos cuidados dos pacientes submetidos ou expostos à pandemia Covid-19. Hoje, em especial, vamos abordar o tratamento da fisioterapia nos pacientes com fibrose cística dentro do contexto da pandemia. Gostaria de agradecer a todos os participantes e avisar que após a apresentação, vocês podem mandar pergunta no menu interativo do aplicativo. A palestra será em inglês e as perguntas e respostas serão traduzidas. Antes de iniciarmos essa discussão, gostaria de falar que esta atividade faz parte de um programa de capacitação profissional que vem sendo elaborado há aproximadamente 4 anos, entre a parceria da Sobrafir e o Grupo Brasileiro de Estudos em Fibrose Cística. Sua primeira etapa foi a publicação das Diretrizes Brasileiras de Fisioterapia na Fibrose Cística, que foi publicada no ano passado na revista Sobrafir Ciência. O nosso segundo passo foi o restabelecimento da representatividade internacional do Brasil dentro do Grupo Internacional de Fisioterapia na Fibrose Cística, que está sendo representada pelo professor Márcio Vinícius Donadio, professor da PUC do Rio Grande do Sul. E já em processo de estruturação e captação de recursos, nós estamos elaborando um curso online para em relação aos cuidados de fisioterapia dos pacientes com fibrose cística. Nada disso seria possível se não tivéssemos várias pessoas especiais empenhadas a nos ajudar nesse árduo caminho. Em especial, queria ressaltar a importância do núcleo de fisioterapia do Grupo Brasileiro de Estudos em Fibrose Cística e a nossa associação, a Sobrafir, que desde 1986 tem arduamente lutado pelos interesses das especialidades que ela representa. Esse evento será coordenado por mim, Evanilson. Eu sou mestre em fisioterapia pela Universidade Cidade de São Paulo, sou doutor em ciências pela USP e professor do campus Betim da PUC Minas. E hoje também sou fisioterapeuta do Ambulatório de Doenças Raras pelo Centro de Referência de Fibrose Cística do Hospital Infantil João Paulo II, da Rede FEMIG. Quem vai moderar essa atividade é a doutora Adriana Della Zuana. Doutora Adriana Della Zuana é mestre em ciências pela Faculdade de Medicina da Universidade de São Paulo e fisioterapeuta domiciliar nas áreas de fisioterapia respiratória e neuromotora, além de ser uma engajada pesquisadora na pesquisa clínica com pacientes portadores de fibrose cística no Instituto da Criança do Hospital da Faculdade de Medicina da USP. E a nossa grande convidada da noite é a doutora Brenda Button, uma fisioterapeuta de renome internacional que tem dedicado a sua vida profissional para o tratamento das doenças pulmonares, tanto na população pediátrica e adulto, em especial os pacientes com fibrose cística. Doutora Brenda tem uma grande capacidade de agregar toda a cientificidade de uma pesquisadora ao domínio técnico e a capacidade humana necessária no manejo clínico dos pacientes. E agora, para começar a apresentação, eu queria convidar a doutora Adriana Della Zuana para fazer a introdução da nossa convidada.
Okay. Good evening to all. First, I would like to thank all of you who are attending this webinar tonight. Thank you, Dr. Brenda, to be here tonight with us. This session was jointly developed by a Sobrafir and Brazilian Cystic Fibrosis Study Group to discuss the physiotherapy care for cystic fibrosis patients during the COVID-19 pandemic and the lessons we may take for the future. So, to address the topic, physiotherapy in cystic fibrosis from pandemic to the future, I would like to introduce Dr. Brenda Button, who is a physiotherapist and adjunct clinical associate professor from the Department of Respiratory Medicine, and Physiotherapy and to the Alfred Hospital, and the Department of Medicine, Nursing and Health Science from Monash University, Melbourne, Australia. Please, Dr. Brenda, feel free to begin your presentation.
Thank you very much. Thank you for inviting me, and I hope I will be able to speak in such a way that everyone will understand me. What else?
Take your time.
There we go. Oops. There we go. No, okay. Okay. Good evening, everybody. I'm in tomorrow morning, so I'm at 9 o'clock in the morning, and you may hear some announcements over our loudspeaker system, but I'm in a hospital, so just please ignore those. So what I'm going to be talking about to you today is the management of CF during COVID-19 lockdown. And I'll talk about a little about the demographics, so put it in context, physiotherapy management for inpatients, hospital in the home patients and outpatient clinics, telehealth, difficulties experienced during this period, managing the challenges, projected changes into the future, what do we think is going to happen, and then we'll have some time for questions and discussion. So I live in Australia, 13 hours ahead of you, so on the other side of the world, but also in the southern hemisphere under the same sky. And these are the different states in Australia: Western Australia, Northern Territory, Queensland, New South Wales, Victoria and South Australia, and Tasmania down here. And I'm presenting to you from Victoria. So this shows a little bit about our population of our country. So these are all the states: Western Australia, Northern Territory, South Australia, Queensland, New South Wales, Victoria, Tasmania, and the Capital Territory. We have about 25 million people. And you can see Victoria, where I live, is one of the most populous states. It's a smallish state with lots of people, and New South Wales is the other very large state. This shows the numbers we've had of COVID patients in Australia during the pandemic, so just under 8,000 altogether. In Victoria, we've had about 2,000, and in New South Wales, about 3,000. And these are the number of deaths, 104 in the whole country. In Victoria, we've had about 20. And
Dr. Brenda?
Yes?
Your presentation.
Yes, can you hear me?
Yes, your presentation, you are going to share with us your PowerPoint?
I've got it up at the moment. Can't you see it?
No, not yet.
So, well, I've been talking for the last 5 minutes.
I'm sorry for that.
Can you see it now?
Yes, thank you.
You can see it now?
Yeah.
You sure? All right, I'm sorry. Have you been listening to me or just not hearing me talk?
We are listening to you, but we don't see your PowerPoint.
Okay, so you've heard the first part. This was what I'm going to be covering today. And then I'm talking now about Australia. Can you see me now?
No.
Can you see our show screen? Can you see it now?
No, Brent. That's it. That's it. Thank you. Now we can see you.
You can see the screen now?
Yes, now we can.
Okay. So, and you can please speak up if you can't see it.
No, that's okay. Now we can see. Now
all right, so
everybody's seeing you.
So here we are in Australia, and here I am in Victoria, one of the most populous states, 8 million people. And these are our total numbers of COVID in patients in the pandemic. And these are the number of deaths in Australia. And that's Victoria number of deaths. And you can see that's proportionally quite a small amount compared to the rest of the country. If we look at this one, this is yesterday in our state of Victoria. This is during the pandemic, and we've been flattening the curve, and here we're just having a little spike at the moment. We've gone into lockdown for a number of suburbs where people haven't been doing the right things, and so they've locked down certain suburbs. Current hospitalizations, there are only 16 in the whole of Australia of patients with COVID. That's not CF, that's just general patients, 16 in Australia in hospital, and only 1 in ICU, not intubated. This patient is an older pediatric patient who's hard to control, so they're keeping him in ICU so he doesn't infect other people. And then here you can see some of the statistics about our population testing. So we've tested over around 2.5 million people so far, and about 0.3% show up as positive. So if I tell you now about our hospital, the Alfred Hospital is a large tertiary hospital in Melbourne, Australia. We normally have between 500 and 515 beds. It's a large adult CF centre that I work at with about 350 patients who range in age from 18 to 78. Australia-wide, in the whole country, we have about 3,000 CF patients. And if we look at CF, COVID at the Alfred so far, 0 with CF cases. We haven't had any touch wood with CF. We've had 5 general patients in ICU, 2 who died with underlying health conditions, with cancers, 1 who was on ECMO who recovered and was discharged. And there have been about 40 inpatients at our hospital during the whole pandemic, general, out of the community. About 20 of them would have had COPD, none with CF, no CF patients, and no post-lung transplant cases yet either. We think there are about 3 cases in the whole of Australia that we know about of CF patients with COVID, and they've all been okay, they've all done well. And then the Journal of CF has published a publication which you can all read up on. It's the Journal of CF, Scott Bell et al. It was published in March, where they looked at 8 countries, these are all the countries, where there were about 40 cases. And there were no deaths reported in any of these cases. And you can see only about 1/3 of them required oxygen. When we look at a Vertex seminar recently in 12 countries that was presented, 60 had CF patients had COVID, and there had been 1 death amongst that whole population, but relatively similar. Patients did relatively well. Yesterday I found a study by Carlo Castellani from Italy, and he reports 2 mildly symptomatic cases in Italy of CF with COVID. So we wonder why CF patients seem to be doing very well. Probably it's because they've been shielding in isolation, being at home and not being out in the community, and not getting all the other colds and flus as well. So what happened at the Alfred Hospital during lockdown? Our first case was detected in Melbourne on the 25th of January. So early February, our hospital started getting telehealth sorted out for all of our outpatients. We've used telehealth on a small scale for many years, maybe 3 or 4 years, but not for our whole clinic. Patients were being educated and set up with telehealth technology. And on the 9th of March, we had a massive influx of COVID suspect patients to our emergency department here. The hospital then was already preparing for a large influx of patients to the wards and to ICU. And in early March, our whole community locked down progressively. That meant that all organizations made arrangements for working at home, if they possibly could. And computer and internet challenges were huge, with a huge lot of overload. On the 22nd of March, there was widespread use of telehealth started for our CF patients shielding. So it was towards the middle end of March that our patients really went into lockdown, and routine lung function testing stopped for inpatients and outpatients. So in our community lockdown, everyone had to stay at home. They were only allowed out for exercise, shopping, emergency work, and medical treatments. All of our restaurants, bars, theatres, gyms, pools, sporting clubs and teams closed down. Schools closed except for emergency workers. And our motto was, if you can work from home, then you must work from home. And this was to limit the movement of people and to limit the contact between our population and decrease the use of public transport only for essential workers. So we faced many changes. All of our hospital groups, meetings, ward rounds, presentations, large gatherings were cancelled, and everything became virtual. Telehealth format for lectures, meetings using Microsoft Teams and Zoom are our two most popular platforms. Our platform for patient telehealth is Health Direct, which is a Victorian government platform. And we have developed remote access for staff working from home. So we all had home access to patient information, so we could get in and see what all of their results were and be able to enter details of our discussions into their charts. We had to get a lot of information from our IT, information technology department, and our physiotherapy department. Instead of all meeting in one place each morning at early, we'd all have to go into different parts of the hospital and Zoom in on telehealth with Microsoft Teams. The hospitals limited our number of people in a space, and we strictly now still adhere to 1.5 meters personal distancing. Now we still get temperature checks as we come into the hospital. Security guards control the movements of visitors, and there's no minimal movement of staff between floors. And at the beginning, there was no movement of staff between floors. So if you worked on the 5th floor ward, you stayed in that ward for the whole day and didn't move around. And this was for case contact identification, so that they could identify which staff had treated which patients that may have become infected. So in preparing for the surge, hospital beds were reduced. We got sent a lot of patients home, anyone who could go home. So instead of having about 515, we went down to about 300 patients in the hospital. We now have up to about 400, so we're still not to full occupancy. ICU capacity was increased. That was doubled. Normally we have 56-bed ICU. It's now has the capacity for more than 100 beds, but we haven't luckily had to use that. Our emergency department has expanded maybe from about 50 to about 200 beds. All elective surgery was cancelled at public hospitals, and elective surgery was cancelled in private hospitals as well, so that the public hospitals could, if they got too many patients, could flow into the private hospitals. There was extra intensive training of staff, especially putting on and taking off personal protection equipment, and the importance of hand hygiene, lots and lots of education about that, and hand sanitizers distributed all over the hospital. For our patients, our ward-based model became the new way of working. So instead of our specialist CF physios being able to go to where all the patients were, either in the acute respiratory ward or in outlying wards or in wards where they have tune-ups, normally we have patients in 3 different parts of our campus, we were now confined to just one ward, one floor. And this ward became the ward for immune compromised patients. So on that ward were CF, respiratory patients, lung transplanted patients, and hematology was added into that ward. There was a lot of ICU upskilling for all physiotherapists on the wider Alfred campus. So physios were brought in from other parts of Alfred Health to be upskilled, to be able to work in ICU if necessary, where maybe they wouldn't have done that for years. There was proning training for all of these physios, which we thought there's belief that proning is a good strategy for patients who are intubated and ventilated. And they employed 90 new allied health assistants who, if we had the big surge, would be able to do the work of the physios who would have been out in other parts of the hospital. They would have been doing their work and they would have been working in ICU. Visitors were limited to 1 per day per patient with a maximum of 2 hours. Our personal protection equipment is all the usual gowns, masks, goggles, gloves, and the correct putting on. We call that donning and doffing, correct putting on and taking off, and of course hand hygiene. And all staff and patients were encouraged to get flu vaccinations as soon as possible. When our patients come into the hospital with any kind of a respiratory infection, they have to go for COVID testing, and they have to go to the COVID ward, which was on the 7th floor, to be tested. And then if they're confirmed, then they stay on another part of the 7th floor.
Staff may call 5 East Respiratory 1. Additional staff may call 5 East Respiratory 1.
So when the patients were treated on that different floor, on the COVID ward as we call it, there were dedicated staff with optimal PPE, personal protection, strict guidelines about patient-staff contact. We were trying to minimize patient-staff contact as much as possible. No face-to-face physiotherapy supervised treatments. Patients were set up to do their treatments independently, so the physio would set them up and then leave the room. Telehealth was used if we needed to supervise a patient directly while they were doing their treatment. We would do it via telehealth. So we would set up a screen in their room where they could see us and we could see them. CF patients were managed by the CF team via telehealth, but then if somebody had to go in to do something for the patient, then one of these dedicated staff under our supervision and guidance would go and see the CF patients. And patients had to have 2 COVID-free tests before they could be transferred down to the respiratory ward, and that's still the case today. So our physiotherapy treatment restrictions were no nebulized treatments while being tested. However, if the patient was at risk of being deteriorating without those treatments, then we had to speak to the patient's consultant, and that consultant could give permission if he or she thought that that was reasonable. In that case, the patient would be set up with their inhalational equipment in their room. The physio would leave the room. A sign would be put on the door with the time of the inhalation starting, and nobody would enter that room for at least 30 minutes, up to 60 minutes optimally, after the patient had finished taking that inhalation, so that all the particles could settle. And then if supervision was required during the inhalation, we would do that via telehealth. Airway clearance therapy was carried out at arm's length. So in other words, if they needed some airway clearance equipment, we'd ask the nurse to take it in, and we'd maybe stand at the door and discuss with the patient what they were going to do, or do it via telehealth. But we tried very much to limit people going in and out of the patient's room. Routine observations like blood pressure and heart rate and SATs and all of those things were done by the nursing staff, and the whole aim was to minimize patient-staff contact as much as possible. So what do we do for physiotherapy at the Alfred? We do what we call modern airway clearance therapy. Positive expiratory pressure therapy using masks, mouthpieces, or combined with mucolytics. Oscillating positive expiratory pressure, flutter, aerobica, a cappella, and bottle pep. And then autogenic drainage, active cycle of breathing combined with mucolytics. Metaneb, intrapulmonary percussive ventilation, only in patients who are not doing well on their usual airway clearance with mucus plugging. Positioning is individualized. Often it's in upright sitting. Sometimes it's in left or right side lying, horizontal like in this patient, supine or prone horizontal. But we do no postural drainage percussion, and we do no head down tilt for any patient in Australia. And I think in the rest of the world. So head down tilt has completely been stopped. That was part of the last century because of all of the research. And then huffing and coughing we do intermittently when the secretions reach the upper airways. Exercise while patients are an inpatient. They used to always come to the gym one at a time, but this gym has been closed, and they are now were restricted from walking outside in the park opposite the hospital, which they also like to do a lot. So patients had to do exercise in the hospital room. We put a bike in the room, or a step, or some TheraBand, and we encourage them to do squats and heel raises and walking or marching in the room, trying to prevent them from deconditioning while they were in hospital, and no leaving the ward. Hospital admissions for CF patients during the pandemic has reduced by 50%. There's just been a much fewer patients in the hospital. They have, if they've come in and they're well enough, they're discharged as quickly as possible to hospital in the home. And we think that patients shielding in isolation at home has decreased their exacerbation rate. So they're not getting all the other coughs and colds and flus that they would normally get from their children or from work, mates or their friends, and which would then cause them to have a CF exacerbation. So this decrease in other common viral infections we think has contributed to this reduction. But also many of them have been put on gene therapy in the last couple of years, and probably about more than 60% of our patients are either on ivacaftor or Cambi, Symdeko, and Trikafta. We started getting compassionate access early in 2020, and that's helped a number of the sicker patients a lot. Outpatient management of CF we've done with telehealth, so patients in their homes are able to be seen by the physiotherapist, and this is our team. We have a multidisciplinary team. About more than 99% of our CF population has been managed at home via telehealth, and our multidisciplinary team is medical, physiotherapy, nursing, nutrition, and psychosocial. The psychologist and social worker have played a very important role. The only objective measure we've had at home is what we call our Alfred Wellness Score, our OR score, which I have presented internationally over the last few years. It's a 10-point wellness questionnaire, which we physiotherapists have been completing with the patients while they're on telehealth. And this is what the OR score looks like. It's 10 points, 10 questions, 5 domains. So 2 questions for respiratory, 2 questions for physical activity, energy and exercise participation, nutrition, psychological, mood and anxiety, general health or sleep amount and quality, and general health. And if you, 10 is you're really well, 0 is you're really, really unwell. So we ask the patient to tell us where they are on the scale at the moment for amount of coughing they're doing, how much sputum they're coughing up, what's the energy like, what's the exercise participation, etc. And the higher the score, the more well they are. If you get a score of 100%, then you are perfectly healthy. So this has been helpful for us during the COVID pandemic to get an idea of what the patient's whole function is like in all of these domains. And when they've scored very low on mood and anxiety, this has triggered a referral to our psychological team, our psychologist and our social worker. So that's really helped us to pick up those patients who are not doing so well psychologically at home. Pharmacy has become much more flexible. They now courier medicines to patients' homes, and so for country patients that's fantastic because they don't have to drive to the hospital to pick up their medications, especially all the gene modifier medications which they can only get from our hospital. And this has helped decrease the contact of patients with the hospital. We've sent out educational newsletters on a weekly basis, things like being creative about exercising at home, nutrition, psychology, sleep hygiene, management of anxiety and isolation. And then social work has been assisting with financial issues and work-related concerns and work-related arrangements about working from home. Patients have expressed a lot of fear about COVID, especially in the beginning. Fear about getting it from their community, fear about coming anywhere near the hospital, fear about coming into the hospital because they know they're going to have to go to the COVID ward to be tested, and they have to have 2 COVID-free tests to be able to go to the respiratory ward. So physiotherapy at home, our patients do independent airway clearance therapy. We don't have anyone doing percussion at home or needing somebody to come and do something to them at home. They all do it independently. They use adjunctive inhalational therapy, and exercise at home, they need to be creative. So home gym setups has become very popular because a lot of our patients like to go to the gym. YouTube and videos from the internet, there's so many, there's thousands of them, and many of them are free. Daily walking outside we've encouraged for physical and mental health, especially for the mental health aspect as well, getting out in the sunshine and having a good walk, and maybe walking the dog. And a lot of patients have done yoga. More time for airway clearance and exercise is what a lot of patients have reported. Because they're working from home, they're not rushing to work, they're not quite so busy, they've had more time to look after themselves, and many of them have become much fitter. Some of the difficulties we've experienced in CF care is that that change from a respiratory stream-based model to a ward-based model, where the CF physios couldn't go and see all the CF patients, where we had to get others to help us out and had to do telehealth. That's been difficult, not being able to see each patient. Supporting patients when they're in other wards with telehealth has been challenging because you need to have a good platform to be able to do that virtual treatment with. Physiotherapy students have been challenging because we've tried to limit the number of patients, people that patients see, but we've decided we have to be creative, and so we've been doing that in a very creative way, and we can talk about that more if you're interested in that. PPE and limitations to nebulized airway clearance treatments. So patients not being allowed to have their usual airway clearance treatments supervised and not to be able to have their usual inhalation treatments supervised has been challenging. And not having objective measures like lung function tests and exercise tests has been a problem because it's harder to know what patients are doing. No oximetry for outpatients. We haven't been able to see what their SATs and heart rate are doing. And we were doing a lot of exercise testing before patients were starting gene therapy, our CPET or our A-step, which is our new maximal incremental step test that we use with our patients. They've all had to stop together with lung function. So we have been flying a bit blind, not really knowing what's going on with patients' lung function, but the OR score has been very helpful as an objective measure. And we think that the patients who record themselves as being well probably are very well because they're not getting all those other viruses. We also have used exercise tolerance and participation, so how much they're doing compared to usual as a measure of their wellness, and how short of breath they feel when they're exercising. So that's been a helpful measure. And we are looking forward to, in the future, looking to see how the trends of the OR score are in comparison to lung function tests. Positives from the pandemic for us, working from home, for many people in the community had better home life balance, so they're not all spending an hour on the train getting to work. Instead, they can spend time with their children or their partner in the morning and the evenings when they'd normally be going on a train. Greater services and flexibility from our hospital departments, like pharmacy delivering drugs. Mailing equipment to patients is what we've had to do. So if they've needed some airway clearance equipment, instead of we'd give it to them in outpatient clinic, we've had to mail it to the patients and then sometimes teach them over the internet how to use them. And that's worked. It's worked well. It's not ideal, but it's certainly been better than nothing. Supervising treatments during telehealth, we've certainly done that. We've had some patients who've really needed the physio to supervise them, and we've maybe had a weekly call to them with telehealth and spent half an hour supervising them doing their treatment and encouraging them. I assisted in one ICU extubation of a CF patient who came in after a drug overdose. And so I was on telehealth, and we had two quite inexperienced physios in ICU who I was able to supervise, and we did a very successful extubation. Teaching of students via telehealth. I've done one airway clearance course with our students, which was interesting. and leading our team. So, you know, I'm a team leader and leading my teams. I've had to do that all via telehealth in the early days. Now things are starting to loosen up and we're starting to have more face-to-face contact. So what do we think the future is going to be for CF? What are we going to take out of this COVID pandemic that might be good for the future? We think they're all going to start thinking about home spirometry, and we're looking at the moment into what's the best spirometer that they could use at home, because that would be a really good measure. We think there'll be increased use of telehealth. So maybe instead of coming to the hospital every 3 months, they might come every 6 months to the hospital, and the other 3 other clinic visits have at home on telehealth. So maybe we'll have fewer face-to-face meetings and more at home via telehealth, except when patients, of course, are very unwell, then they would come to clinic. So we believe that we'll probably have a mixed model in the future, telehealth and face-to-face reviews. Country patients in that case will be better served with the mixed model because they won't have to travel so much all the time and spend time away from their work or their family. Flexible pharmacy will have long-term benefits. And patients and families, I think, are going to appreciate the value of isolation and shielding, because often we have patients telling us that their friends and family and people at work are so inconsiderate that they come to work sick and sit in the desk next to them, or they come and visit them at home when they have a bad cold or the flu. And we think that this whole pandemic is going to make the whole community more appreciative of how we need to socially distance and hand hygiene and all the good things that go with trying to prevent infections. Masks are a question in Australia. Many of us think we should be using masks out in the community more and more standardly all around the hospital, but it is a big question mark for us, and we can maybe discuss that in the future. So I have really questions. We have questions. You probably have the same questions. What will the future bring? Will patients have had a step down in their lung function when they've come back to clinic and actually do their lung function tests? We think maybe not. Maybe because they've been so well in isolation, maybe their lung function will be very stable. So that will be very interesting to see. Will patients have fewer viral infections and influenza this winter? If there are fewer exacerbations, will their lung function be better preserved and will have fewer hospital admissions? And what are going to be the outcomes of mental health from the pandemic? You know, many of our patients have had a lot of anxiety and low mood, and is that going to be worse than usual? What will happen to fitness, physical fitness, when we next do a CPET or an A-step maximum exercise test? Are we going to find that they're actually fitter than they were before, or they've maintained their fitness, or they've dropped their fitness? Will fewer hospital admissions be the way of the future? How will this affect our physiotherapy staffing models? Because we're all staffed to have physiotherapists to treat inpatients. Will we take physiotherapy to the home? Will we start, instead of seeing them in the hospital, seeing them on hospital in the home, which we don't do at the moment? And will CF care become more of an outpatient model? What will be the outcomes from gene modulator therapy in the long term? Is this the cure that is going to make patients live much longer and much more healthy lifestyles? So we have a very exciting, challenging, and unknown times ahead. And these are some of the references that I would recommend. The blue booklet, which is the booklet giving all the different airway clearance techniques by the developers, which is on the ECFC website. Physiotherapy for CF in Australia and New Zealand, a clinical practice guideline, which is on the TSANZ website, and cfphysio.com, which is a website for instruction and videos for physiotherapists, and we know getting one for patients as well, and then the Journal of CF. So that's really all my presentation I wanted to make. So I'm going to ask the question, do you want to ask me questions now, or shall I go to the questions that you sent me?
Thank you, Dr. Brenda. Dr. Adriana, going to ask you some questions right now. And
Okay.
after that, we can make another question from audience.
Okay, so shall I close this down, or shall can you still see me?
Yeah, we can see you.
Okay, All right.
Yeah.
Well, I'm listening.
Okay, after your speech, Dr. Brenda, I would like to ask you, would you believe such this telehealth that you said, that you told us, will work well, will work for like a near future or for a long term? What do you think?
Are you talking which particular part? I missed the first part that you said.
About the telehealth that you use
Telehealth.
with the patients, like for doing exercise, for doing procedures or whatever you want to teach to your patients. Do you think this telehealth is already working, right?
Yes, look, I think it's working to a degree. It's not perfect because you can't feel or touch or measure. So I think that it'll be a mixture. In an ideal world, it'll be a mixture. At the moment, we're in lockdown, so we can't do anything different. We have to do it that way.
Yes.
But I think we're learning new ways all the time that we can use telehealth. For example, I had a patient who she had a liver transplant, and she has quite bad lung disease, but they didn't do a lung transplant at the same time. And she was very anxious and she was not exercising and she wanted to build up her confidence. So I rang her every week. We did telehealth and I would supervise her doing an airway clearance session, watch her doing it and talk to her while she was doing it. Modify some things over the internet, and also be able to go for a walk with her down to the mailbox and back. So we could walk and talk because we had a mobile device. She had a mobile device, and I could see how she was performing, what her exercise was like. So I think there are aspects of it that are very useful, very helpful, and we could do groups of exercise treatments, which we haven't been able to do. I think there's a lot we can do with telehealth, but there are some things where you really need to be able to see the patient and feel what's going on, and have a look at their posture, measure their posture if they've got musculoskeletal problems. I think there's a role for a mixed model is what I really think is going to happen. So we'll get them to come in when they really need to come in, but when they don't really need to come in, then we can see them on the internet.
Okay, I will translate. Você quer traduzir?
You can do that.
I can do that. Bom, a doutora Brenda disse, eu perguntei sobre a telemedicina, né, telehealth, que ela chama, e ela disse que, na verdade, é um modelo que eles ainda estão aprendendo. Durante a pandemia, não teve outro jeito, outra forma de atender os pacientes, a não ser com o distanciamento social. No entanto, o que é ideal que se faça, ela diz que tem muito a aprender com esse novo modelo de atendimento. No entanto, é interessante que você faça uma mistura do paciente ir até você ou dele ser atendido por essa forma de telemedicina. E a gente tem que observar paciente por paciente, porque ela contou a história de uma paciente que sentiu muita ansiedade, muita tristeza durante a pandemia. Então, nesse caso, ela tinha que interceder de uma forma mais incisiva, telefonar mais para o paciente e uma certa vez até, eu acho que eu entendi assim, que ela teve até que se encontrar com esse paciente, porque realmente essa pessoa estava realmente precisando bastante.
There is one. I'm going to ask another question from audience, Dr. Brenda. Someone asked if there is some difference between hospital entrance for patients who have COVID-19 and a patient who have CF and COVID-19 together. If there is some difference from care inside the hospital or inpatient.
Well, look, we haven't had any experience to talk from, unfortunately. And when we talk to international people, and you find out what the pathology of it is, we're not sure whether it's actually going to make a big big problem for the chests. And I think to begin with, we would just treat them with normal, usual kind of airway clearance to improve mucociliary clearance, to get rid of mucus plugging, to open up the airways, and just to optimize respiratory function. I think if we just don't know, and I haven't got any indication from any physios around the world who've actually treated a CF patient who's had to talk about different things. So I think that's something that we will learn more about once we come out of the COVID thing and we start going back to conferences and we start hearing what people were doing. What are your thoughts?
I share the same opinion that you have. We do not have so many patients with COVID-19, especially
We've had 0, and there've only been 3 in Australia, and the physios haven't reported that they had to do anything special. They just did a normal treatment, IV antibiotics, bronchodilators, the usual things, pulmozyme,
hypertonic saline solution, antibiotic.
Hypertonic saline, normal saline, all the usual things.
Ok, eu perguntei à doutora Brenda se existe uma diferença do fluxo de um paciente com COVID e um paciente com COVID-19 e fibrose cística. Ela falou que ela não tem experiência com pacientes com fibrose cística com COVID-19 porque eles não tiveram nenhum caso. E que os cuidados que geralmente serão implementados são os mesmos cuidados que a gente utilizaria para uma fisioterapia respiratória geral, como ela colocou na palestra, mas que provavelmente nos próximos eventos nós vamos ter outros colegas que vão falar qual que as condutas diferentes que eles tiveram com algum paciente com fibrose cística, que até o atual momento ela não tem. Ela me perguntou se a gente tinha alguma expertise, alguma experiência aqui, nós falamos que também aqui no Brasil nós não tivemos nenhum paciente com fibrose cística até o momento que eu atendesse com COVID-19.
I have a question. Can I?
Yes, certainly.
How often that questionnaire you showed us, it was applicable for the patients that they were? I understood that questionnaire you're using when they were at home, right?
Yes. So the OR score takes 1 minute to complete.
Really?
It's very quick.
But you use it for adults, right?
We use it for adults. And we've got some physios around the world who are looking to see whether they can adapt it for children. I think it'll work very well for teenagers. We haven't tested it.
Yeah.
We've tested it in adults, but it might work very well for teenagers. And it might work for parents of younger children.
Really? Good.
So if you ask the same questions of the parents, how much is your child coughing in the day and the night, they'd be able to say whether they're coughing more or less or the same.
Good.
And or somebody's also looking into maybe using the little faces, the happy face and the sad face.
I know. Great.
But it's been very useful because it gives you the whole picture of the patient, not just the physio part or not just the nutrition or not just...
Many parts.
Many parts, and particularly to pick up on mood and anxiety, because patients don't usually talk about those things to the team unless you ask them. And because it's in a questionnaire, it's not threatening. It's comfortable to answer the question, yes, my mood is low because I'm missing my work, or I'm feeling very anxious.
Really good. I will translate to them. Eu perguntei para ela com que frequência ou como era aplicado aquele questionário que ela comentou antes que ela faz para os pacientes na telemedicina. Ela disse que não leva 1 minuto para preencher aquele questionário, que ele é muito interessante porque ele expressa, como ele tem vários domínios, ele pode expressar várias partes da pessoa que está, que tem a fibrose cística, que está em casa fazendo as suas coisas, enfim, E ela disse, eu perguntei se dava para usar com crianças, já que aquele questionário eles fizeram para atendimento de adulto, a aplicação dele para adultos. Ela falou que pode ser de 2 formas. A gente pode usar o mesmo questionário, que você pode fazer as perguntas para as mães, para os pais, para os parents, que são os pais ou os cuidadores, E também existe um formato novo que está sendo, está sendo investigado ou pensado com carinhas e que é muito interessante, que responde sobre vários domínios do paciente, em relação a vários domínios, né? Que tinha ali a parte psicológica, a parte nutricional, a parte da físio, e que não leva mais de 1 minuto para fazer aquele questionário. É muito interessante o resultado dele. Do you have any questions? Vanessa?
I have another. Yes, I have. Brenda, in your opinion, cystic fibrosis patient characteristics have changed over the time? Do you think the new possibility to change physiotherapy for just exercise with the new therapy for the near future?
Look, I think patients who've already got bronchiectasis, if they've got a lot of bronchiectasis, exercise is probably not going to get rid of all that gunk that's sitting in those dilated airways. So I think anyone who's got a lot of bronchiectasis and a big sputum producer, formal airway clearance is going to need to be a part of that. But patients who have got good lung function, especially children and adolescents and adults whose lung function is greater than 80%, who don't have much sputum, who don't have much bronchiectasis on their imaging, I think in those patients, exercise is fantastic and it's enough. Exercise with huffing, I think that's the most important thing. They need to use the huffing and coughing and clearing combined with it. So that's certainly what we do with our adults or our well children and well teenagers is exercise and huffing.
Ok, eu perguntei para a doutora Brenda que, de acordo com as novas terapias, o perfil do paciente fibrosístico tem mudado muito ao longo do tempo, e se ela acha que no futuro próximo a gente iria substituir a fisioterapia por exercício. E ela falou o seguinte, que quando eu tenho pacientes que já têm bronquiectasia instaladas, que ela acha muito pouco provável eles conseguirem tirar essas secreções para fora, esses tampões mucosos, somente com o exercício. Mas que esses pacientes que têm essas características, eles vão precisar de fazer fisioterapia respiratória. E que os pacientes que têm uma função pulmonar acima de 80%, que são pouco secretivos, as crianças, os jovens, os adolescentes com função pulmonar normal, eles vão ser muito beneficiados com o exercício e eles podem agregar durante o exercício a realização do huffing. Isso é uma informação importante porque às vezes a gente implementa os cuidados de fisioterapia em crianças desde nova, crianças que estão bem, isso gera uma certa dificuldade aí de adesão ao tratamento. Então acho que isso é uma grande explicação para a gente aqui nessa conferência. Adriana, do you have another question for Dr. Brenda?
Yes, I have one more. Talking about adherence, do you think the telehealth will help the patients to be to adhere to our treatment, to physical therapy treatment, or doesn't matter?
That's a hard one to answer. Look, I think patients who need a bit of supervision and to get them started, we've certainly done that with a few. We've got one patient who will do physiotherapy and do exercise if somebody gets her started.
Okay.
And so we've used telehealth to get her started, okay, I'm on now, where's your equipment, put it all together, and we just, like we'd have a normal treatment, we would supervise them over telehealth doing stuff. And it could be exercise, it could be an exercise group, it could be doing,
yes,
in their gym program at home. I think absolutely telehealth could help us with improving adherence in those patients who just don't do anything unless there's a physiotherapist with them.
Yes, good. Thank you. Eu perguntei para a doutora Brenda se ela achava que a telemedicina, esse jeito de atender os pacientes, poderia melhorar a aderência ao tratamento, a aderência dos pacientes ao tratamento da fisioterapia. Ela acredita que sim, que inclusive a gente pode, dessa forma a gente pode até montar grupos de exercícios fazer uma coisa diferenciada, mas que muitas vezes o início ele deve ser mais supervisionado e depois pode passar a ser por telemedicina. E o que eu entendi, que ela deu a entender na fala dela, é que vai depender muito do paciente, né? Existem pacientes mais aderentes, independente de qualquer coisa, mas, de uma forma geral, é muito bom porque nós podemos fazer outros modelos de atendimento, por exemplo, atendimentos em grupo. Isso é uma coisa bem interessante para a gente pensar, né? Evanilson, do you have any questions for Dr. Brenda?
I think we have a lot of questions, but our time is not so much to ask and to answer at all. And then I would like to say thank you very much for Dr. Brenda. It was a great opportunity for us. You, Dr. Brenda, inspire a lot of physiotherapists around the world. Your knowledge, your expertise with CF make us to treat our patient better. Então, thank you a lot for that.
And that's a lovely comment. Thank you very much. That's very generous. That's very generous. And my last word is we don't tip any children, babies, adolescents, or adults with CF or COPD or bronchiectasis, because we've proved that they all get reflux when you tip them down. Mm-hmm. And yoga also, when you tip somebody, do the downward dog position when the pelvis is higher than the head, they get reflux too. We've measured that. So we try to avoid all positions where the pelvis is higher than the head. So that's my last word, and I thank you very much for inviting me and for this opportunity to speak with you.
Thank you.
Probably we are going to see you in the near future here in Brazil to celebrate the end of the pandemic and a very good practice for all physiotherapists in the world.
That sounds wonderful, and you know, if that takes a very long term, we could always do something again on this platform.
Yes,
so,
great. Thank you so much.
Thank you a lot.
Thank you very much, and
bye. Enjoy your day.
All the best. Thank you. Bye bye.
Bye bye.
Bye everybody.
Pessoal, infelizmente a gente não tem mais tempo para poder fazer perguntas. A doutora Brenda ela está trabalhando, ela está no hospital, então a gente não conseguiu fazer todas as questões que foram enviadas. Eu, no final, agradeci a presença dela. A doutora Brenda tem contribuído muito para a formação dos fisioterapeutas por todo o mundo. Ela faz parte do Comitê Internacional de Fisioterapia na fibrose cística, tem várias publicações. Se depois alguém quiser o currículo vitae dela com todas as publicações e os locais onde ela trabalha, provavelmente vocês podem me mandar o e-mail ou entrar em contato que a gente envia para vocês, tá bom? Ela deu uma última informação que a gente não deve colocar nenhum paciente, seja adulto, seja criança, seja bebês, na posição de cabeça para baixo, de postura de drenagem, porque já foi comprovado em vários estudos que a posição de cabeça para baixo favorece ao refluxo. Ela também não tem utilizado na população dela, lá na Austrália, não para criança e adolescente, as técnicas convencionais, ela só usa o posicionamento e as técnicas modernas, que são os aparelhos de pressão positiva, o Huff, o ciclo ativo da respiração e a drenagem autógena. Então, a gente, infelizmente, não tem como fazer mais perguntas. Eu queria agradecer a todo mundo pela presença, em nome da Sobrafir, do Grupo Brasileiro de Estudos em Fibrose Cística. Espero que essa palestra, essas informações que a doutora Brenda fez de forma brilhante, possam nos ajudar no dia a dia com o manejo dos nossos pacientes. E eu acho que a missão que fica do que ela falou é que, futuramente, a gente cada vez mais vai utilizar a tecnologia, a telereabilitação, junto com o atendimento presencial para ajudar o cuidado dos nossos pacientes. Doutora Adriana, você quer falar alguma coisa?
Não, só agradecer o convite da Sobrafir, de você, meu amigo Evanilson, do grupo de fibrose cística, do grupo de estudo. Muito obrigada pela oportunidade, estou muito feliz. Vamos fazer outros.
Com certeza. Boa noite. Good
Boa
night.
Noite.
Thank you very much. Bye-bye, everybody.
Thank you.
Bye-bye.
Bye-bye.
Um,